Ron with us today. He actually on short notice agreed to be available for this session, and he's always has so many innovative ideas, and I learn so much from him and get inspired to start doing some things differently as well. So Ron, please go ahead and share with us what you're doing differently this year.
Thank you very much, Gaurav and Namrata, for having me with you guys this year. I don't know whether to thank you really, because you gave me like a week's notice to tell you what I'm doing differently this year. So not much time. So I'm going to be really simple. We've had really high-powered talks on AI and biometry. So I'm just going to talk about surgery and really the simple task of rotating a toric IOL into alignment, which is about 80% of all my phacals. Now, I think most of us do this. We inject the lens near the intended axis, 10 degrees away, and then it's easy to rotate. But here's the question. I think some people remove the OVD before the final placement and some remove it after. I like to remove it first, and then with the IA infusion in the right hand, I'll rotate the IOL into position with a Sinskey hook or a toric manipulator. And later on, it's good in discussion to see what the rest of you do. And of course, so the standard technique is I've gone behind the lens to remove the OVD, and then I've removed the anterior OVD, and then here's the Sinskey hook going in through the side port, and I've got only like a 10-degree rotation here, and that's simple. And you can see that little nudge and little rotation, and the lens is in good position. And that's the standard technique, which I think has served all of us very well for a long time, with good alignment based on the Zeiss Callisto system here. But let me show you something else. So here's another case. And that technique I've been using for a long time now. This pupil is small, the rexis is small, and so it's more difficult. I go in trying to dial this lens into place, and I actually miss the haptic optic junction, as you see here. And I go back in again and find it and rotate it into position. But if you look carefully on the right side of the picture here, you will see that I've actually torn that posterior capsule. There's a lens, there's a line there, and the Sinskey hook had actually snagged the posterior capsule and torn it. And you see that quite clearly here on the right side of the eye. Fortunately, the lens was stable enough, and I didn't really need to fixate the IOL. And this happened not once, but 2 or 3 times. And after that, I took a critical look at the Sinskey hook, which we think is very blunt, and it looks blunt, but it's actually quite sharp. And if you snag the capsule, you can tear it. So I modified it by putting a little ball on the end of the Sinskey hook, which you will see here. And when you do this, the tip is rounded, larger, and much less likely to snag the capsule, even if you do come against the posterior capsule. And as you can see here, we can rotate that easily into place. So all was hunky-dory, but of course, you know, Gaurav asked me, what are you doing differently this year? So I started thinking, how else can the toric IOL be rotated into position? So let's look at this case. Again, typically I'm behind the IOL, removing the OVD, then I come in front and you can see all the cohesive OVD being absorbed into the IA tip. And you can see I'm about 15, 20 degrees shy of the intended axis. And I thought, you know, why not try the IA tip itself? So I just turn the IA tip upside down and engage the haptic optic junction and rotate that last 15, 20 degrees as you saw earlier and see whether it would work. I think some of you may actually have done this before, but I guess we haven't thought too much about it or talked too much about it. And you can see here, just by using this inverted IA tip, I'm able to rotate this Vivity lens, as you can see, into position without really introducing an instrument in the left hand. Here you can see that apart from the good alignment of the lens is beautifully in the back, sitting on the posterior capsule. Now, the other question really is whether you can use it for all lenses. That last case was, of course, an Alcon Vivity lens. Now, this is a Johnson & Johnson Technis lens, and you can see that the haptic optic junction is actually different. And there's a little notch at the haptic optic junction. So here I'm removing the anterior OVD again, and now pointing the IA tip backwards, engaging the haptic optic junction, and doing this little nudge, as I call it, to get it into the axis of alignment. And again, we can see that it works both, not just for the Acrosoft series of lenses, but actually works quite well also in the Technis series of lenses, and gives us a good final toric position. Now, I'd like to share with you a complication. Here, I'm using the Sinskey hook to dial that lens into position. Take it out and just watch for this complication now at the side port. Boom. Did you see that? That was a huge epithelial bulla just blown up, probably by a backflow from the fluid hitting the lid and rebounding backwards. And you see there's a huge blister extending to the visual axis here. I can tell you the patient was not happy the next day. It was painful. The vision wasn't good. And I had a time explaining it. And here's the OCT of the side port incision. And you can see on the right, the OCT image shows the detached corneal epithelium very, very clearly. And despite all efforts to starge it back, it really stayed there. And it really took nearly a week for this to settle. I probably should have put a bandage contact lens in. And at the end of the day, it took her about a week before she said she would let me do the other eye. But she asked me, "Doctor, how are you going to ensure that this does not happen to my other eye if I've got a sort of basement epithelial weakness, as you claim that I may have?" So I said, well, we'll try and instrument the side port as little as possible. And this is what I'm doing again with my inverted IA tip rotation. This is like a 30-degree rotation of the panoptic toric in this case. And by doing so, it means I have to introduce instruments less into that side port and hopefully just prevent the small risk of this corneal epithelium going up again. So again, you can see that after doing this rotation, the lens is sitting quite nicely there. And I'm glad that this corneal epithelium behaved. And you can see here the lens again sitting beautifully in the capsular bag. And when I scan over to the side port incision, we can see that's a side port incision. And I make sure I didn't hydrate this as well, just to reduce that risk of me ballooning up that epithelium again. So this is what I call the IA tip nudge rotation of the toric IOL using the inverted tip, which fits the junction nicely. And the advantage, of course, you have continuous infusion in a deep chamber. You also don't get in the way of the toric manipulator because sometimes you put the manipulator in and the IA tip there, they get into each other's way, and you do get one less entry and exit through the side port. So my final clip is that this other one, the rexus is a bit small. So even if the rexus is small, you can actually just nudge the rexus to one side. And in this case, I'm going to use the proximal haptic just next to the incision, as you see here. Just to show that you can actually use this technique, whether you're doing the distal haptic or the proximal haptic, it actually works very well to help position the IOL into the desired final axis position. So just to sum up, the IA tip nudge technique for toric IOL placement is obviously easy if you have a large CCC and a well-dilated pupil. And you can actually nudge it whether proximally, distally, or you can nudge both haptic optic junctions, and you can actually do it at all meridians. So I'd like to thank you for listening to my simple sort of new thing that I'm doing this year, and welcome all of you to our June APA CRS in Seoul. Currently, we're still planning a physical meeting for all of us. We're just waiting for the Koreans to open up a VTL despite their numbers, as seems to be the case all over Asia now. We have high cases, but everybody is relaxing now. Thank you so much for having me.